That's all right. They can heckle from a distance. That's okay. So thanks, Sam. Thanks for the introduction. Thanks for inviting me to come and talk today. Whether you feel that my work is wonderful at the end of this, well, I'd be interested.
You wouldn't be invited.
Yeah. So the title was Big Data and Mental Health, which is kind of over-inclusive. What I'm going to try and focus on today is just some sort of, I suppose, applied examples of how we're using kind of big data methodologies, i.e. the ability to harness huge data sets that are routinely collected, and process them quickly in order to get some sort of actionable insights about what a particular service or a particular health policy should think about in terms of future actions to improve child mental health. So I'm going to sort of subtitle this as these are the attempts that I've made with others to think about how we speed up and make the assessments more efficient. We have a real difficulty in mental health services is that we just don't get to young people quick enough at points of need. So this idea of being able to see how can we identify young people better in the population, and then also how do we sort of maybe refine our assessment processes as well. So take advantage of the technologies to be useful adjuncts to clinical care. So I think basically this is my sort of mission statement for my life really, is to see if we can actually get methods in place to provide fair access to CAMS, assessment, diagnosis and treatment, so child and adolescent mental health. And then I've kind of three sort of missions really, is to see if we can actually accurately identify children at high risk for psychiatric disorder within the population. How can we do this in a low-cost way? How can we improve the sort of information that we know that we should collect? How can we use sort of technology to improve our capacity to symptom, monitor, track more accurately over time? And then is there anything that we can do that really improves our capacity to make more accurate assessments? So can we, things that are adjunctive to the face-to-face interactions that we conduct in clinical practice. This is not the first idea that people think about using large-scale screening methods to see if we can, and how good sort of questionnaire, short, brief, quick questionnaires are, how accurate they are at detecting particular problems. So this is work that a colleague Agiris Sringaris is involved in, looking at the surveys that are kind of routinely done, or relatively routinely done, in the child mental health population. In the population, looking at, if you just took the 25 item of a strength and difficulties questionnaire, how close does that get you to accurately identifying a child with ADHD? So the idea is that can you go out to the population and get close to a vulnerable population just using these measures? And they do okay. So this was in 7,000 children, and then you're sort of looking at accuracy rates of about area under the curves of about 0.92. That's better than prostatic specific antigen and all other things that we routinely use as screening measures in other medical conditions. It's slightly less specific if you look at anyone that comes into CAMS services. So just taking the group that have a psychiatric disorder, how well is it defining whether they have ADHD versus everything else? But it's passable. It's relatively usable. What is difficult though, as Emily worked with me, is it's not easy to get SDQs measured routinely, or any questionnaires measured routinely within school settings. It takes a lot of setup. You've got to bring in iPads. You've got to put you're getting a double session put aside, and then you've got to do that routinely for every school. So the capacity to actually use I'd say screening methods, unless there's considered a systematic investment within education services, I think is problematic. I don't think it's something that's going to be, some schools will get very good at it and some schools won't. So it won't necessarily allow a fair distribution of screening in terms of being able to identify those that are potentially at high risk of a disorder like ADHD, and therefore trigger schools to do something about it. And we also know that high performing schools tend to be quite good at doing screening, whilst poorer performing schools just don't have the capacity to implement any novel changes within their environment. So what did I do? Well, what did we do? So it was the idea that actually there is huge amounts of data that we routinely collect, and one particular routinely, very large routinely collected data resource is the National Pupil Database. So pretty much anyone under 35 will be have a hit somewhere on the National Pupil Database. If you've been educated in state or private school systems, this is educational attainment and census data that is routinely collected on an annual basis, and there's routine school submissions that go to the Department for Education. And that's been run since 2002, 2003. So it is an incredible resource in terms of it allows there's a school level census that is taken every year, and then educational attainment is added to that, absence measures, whether you're a receipt of free school meals or eligible, whether you're a special, what special educational need provision you've had, etc. So we do routinely collect very large census data from schools, and it's the completion rates are very, very high. Schools need this to provide these data inputs in order to receive funding to get assessed by DFE. It's what Ofsted, etc. rely on. So there's kind of quite powerful policy incentives for these data collections to be quite accurate. And what we did regionally was link the National Pupil Database, so these are all state-maintained children, so we've got a good population denominator, to our child and adolescent mental health service provision. And CAMS is quite useful here in the way that SLAM is set up in terms of CAMS, is that we're pretty much the monopoly provider for all specialist services. So we don't, we tend to cover all bases when it comes to making psychiatric diagnoses, and we then can use our CRIS system to find out who in the population has got various diagnoses. And ADHD tends to, well, it still is sort of pretty much uniquely done by child psychiatrists within the 4 regions that we cover. So just briefly, CRIS is a very large de-identified copy of our electronic patient record system that's held in SLAM. We've got, in terms of kids, we've got about in terms of the whole population, we've got about 39,000 active patients, so currently receiving care on the system. We've got around, or it's actually increased since the IMPART merge, the IAP service merge, to around 450,000 individuals that are held on our clinical record system, and it nudges up by about 20,000 each year. So you can sort of sit still and you can get better numbers. It works, so just to recap, you might have had all of this before, but we collect a lot of information via, this is our sort of front-end interface. So when you see someone in clinic, this is the healthcare record system that you use. A lot of it's structured data, so you drop down menus, and that's quite nice in terms of looking at for analysis, but the lion's share of the kind of clinically useful information is held in free text. And so the CRIS system basically scrubs identifiers from the free text and then allows natural language processing to run on top of that. So we feel that we get much better information by combining these structured information with natural language processing methods, which I'm not going to dwell on too much, to be able to extract out not just diagnoses, but we can actually look at treatments, and also we can look at symptom profiles. What we did was take, as I said, the state-maintained population from the 4 boroughs and link that to our CAMS records. And what that enabled us to do is to look at what educational risk factors are there in the population for particular disorders. So the theory is that if you've got lots of very well characterized population level data, you should then sort of be able to see who is at risk for a particular diagnosis. And if you've got very large, complex amounts of data, the sort of general, I mean, it would be kind of, this doesn't sound very scientific, but you try a couple of approaches. You use sort of conventional regression approaches when you're doing your population modeling, and also then you put machine learning pipelines to it. That's pretty much the sort of standard fare. You can kind of get away without at least trying some machine learning methods now, because they are fairly off the shelf and fairly straightforward to use. So what I was interested in with the group was to see what if we used machine learning methods to look at all of those children that had been held in the school census data and their attainment records, and the way educational attainment is quite concentrated towards primary school. So you get early years foundation profile that comes when you're in reception. You then have a key stage 2, a key stage 1 assessment that happens around year 2, the end of year 2, and then also you get your SATs at age 11. What we did for this analysis is, because most of ADHD is sort of diagnosed around the sort of 7-8-year-old mark, we looked at the kind of population level characteristics. So these are, again, absence records, special educational needs, ethnicity, attendance, etc., and basically gather that information and see how well, if we use that routinely collected information, that would predict a disorder like ADHD. And we ran a couple of models. The models that we really were keen on were the ones that were transparent. So you can put things into kind of very black box approaches which don't give you an understanding of really what the features are. But the lean is really now to provide machine learning models that actually give you some insight to what the feature contributions are. So how much the variables are contributing to the predictive score, as it were, from in terms of the prediction output. So we looked at just simple logistic regression and random forest models. We looked again, I was kind of interested in what happens in the population in terms of how accurate these models are for predicting. And so then, and the way that we set it up is that we removed everyone with ADHD that had these educational variables done prior. So this was looking at proper prediction of who got an ADHD diagnosis using these linked data from the age of 7 upwards. And it was quite compelling. So we got very good area under the curves, and we got quite nice precision metrics. Almost, well, actually as good as running a screening questionnaires within schools. And then sort of fairly similar patterns when we looked at just a clinical sample. So this is not taking on board any clinical information. All this is saying is that for a child that turns up where you know what their educational performance metrics are like, this is how good it is at being able to distinguish ADHD from any other disorders. Now there's a problem with that, is that when you use these types of methodologies, you are baking in the biases that are inherent within clinical systems and services. And one of the things that we are not great at is being able to fairly assess fairly assess those that probably have an ADHD diagnosis. There is no real reason why certain ethnic groups, for example, should have lower or higher rates of ADHD. There is some evidence to say that some groups from Southeast Asia, etc., may have lower rates, but generally across the world, when you look at the systematic reviews and meta-analyses, the prevalence rates are fairly consistent, no matter which country you go from. When you use these machine learning type models, what you tend to find is that you'll bake in what happens in clinical practice, which is you find that ethnic group representation tends to drop, certainly in child populations. When you look at comparisons of black groups versus white groups, you're finding they're half as likely to get an ADHD diagnosis. There's no real kind of causal reason why that is, other than these help-seeking case ascertainment biases. So the worry is about, if you put in black box approaches, that you just don't really pull out these features. And then when you look at the individual sort of impact of these particular kind of, I'd say, social determinants, I suppose, of diagnosis, things that come out really strongly. So these are beta coefficients. So this is looking at English as a first language. So how much that is contributing to the prediction of actually not getting a diagnosis. So we picked up the top five features in each of these models. So this is a logistic regression model, this is a random forest model. And English as a first language came out quite strongly. This is a coefficients, and these are this is an impurity, an importance measure that's used in random forest. So both of these, in both the models, English as a first language is quite a powerful contributor to the overall prediction. So it's saying we are creating, if you use these types of models, you are essentially, if you were to apply them in a school, it would be unfairly selecting those that are at risk and therefore at need for intervention, purely based on whether they had English as a first language or some of their ethnic status. So that's a problem.
Johnny, can I just quickly ask a question? One thing that comes up time and time again with the ADHD is the idea that, say if they're the youngest kid in the class, and I wondered, does that fit in the model, or is that?
Yes, yeah. So we've got summer birth. We've got summer birth in there.
Right.
Yeah. So we've got.
Sorry. Oh yes.
Yeah, yeah. So
sorry, I missed that.
Yeah. No, it's definitely in there. So May to August as a kind of we use as a binary field. Yeah. So that's in the story. Yeah. Okay. And there's lots of discussions about what that really represents.
It's my sort of question that I always.
Fair enough. So I think, you know, and this is applied to ADHD. We're working through ADHD examples. I haven't looked at other types of other disorders in childhood, partly because ADHD was probably the safest disorder to look at in relation to it. How many other groups might be diagnosing and treating it? ADHD is something that's only we really do. So it's got the sort of highest penetration point in our data. So then, we wrote this. We sent this off to the Journal of American Medical Informatics Association, and they bounced back and they said to us, "Well, that's nice that you found this, but could you do something about kind of building in some fairness modelling into it?" And we're like, "Oh God, how do you do that?" So we then went back to the books really, and then found that there are particular models that have only recently developed, and there's very little sort of methodological work yet that's sort of now that we've seen embedded into epidemiological studies or other machine learning based studies that look at clinical outcomes, where you look at trying to identify the sort of privileged versus the unprivileged groups. So who are the ones that are more likely to get the sort of, you know, in terms of case ascertainment, who are the ones that are more likely to be selected on the basis of maybe their ethnicity or potentially gender, which we didn't want to apply in ADHD, or whether they speak English or not. So that, you know, how would you unpack some of these biases using these statistical methods? And then it basically creates these sort of, it puts a weight, takes the parameters from the training test set where you say a priori, actually this is probably going to be a problem, and then you put them back into this reweighting algorithm. And what that does is that it didn't really distort the things that we felt were probably important features, like these writing scores, but it reduced the impact of these other features like English as a first language. So actually, it really, and in this instance, it really dropped off in terms of its importance. So it became off the sort of top 30 features or top 25 features. So it's certainly not mitigating bias by any stretch, but it's doing something to lean it towards something that's fairer for your populations. So in terms of the ethnicity, this is what it sort of did. So you can see that the coefficients are quite dramatically different. Okay, so that's one thing. That's sort of trying to make use of the information that we currently collect as a methodology for identifying those that are at high risk. The second kind of challenge really is then what can we do to improve information that we think we should be collecting better in clinic? So one of the sort of standard things that clinicians are kind of sometimes groan about is routine outcome or patient-reported routine outcome measures. And they're sort of mandated by nice guidance, and it's sort of something that NHS England expects every local service to be able to do, is to provide paired outcomes. So you've got some insight whether someone that's coming in with problems actually has shown improvement under your service. We're not uniquely the worst offenders by any stretch, but across CAM services we just don't do it very well. If you think of so I think the last bit of analysis that came out of NHS Digital, NHS England, looking at paired outcome measures was based on 22,000, just over 22,000 paired outcome measures. That's all of CAMS. That's every single person that's been seen across the country for a year. We've only managed to get paired outcomes on 22,000. If you think the population, about 2 or 3% of the population of children are actually referred to CAMS service, we are capturing a fraction. So we did an audit in our system using CRIS, and we looked at just parental SDQ completion. SDQ is a kind of ubiquitous measure, so it's not particularly disorder specific. It covers the whole age range, so it seemed to be the safest bet, really. So we looked at all children that came into our CAM services between 2008 and 2013, so 2015, and then which is about 36,000. We looked at the ones that actually had a baseline SDQ completed, and then we looked at the ones that we found a 6-month follow-up. So we found paltry amounts of people, so about 8% basically, from the originally accepted referral group. And we found I was sort of increasingly interested in this sort of what biases we sort of again bake in to when you're looking at paired outcome data. How much does it not represent the population that you should be treating? Because we're making decisions about how good services are and actually recovery rates. So it's interesting to see if we actually help, the same populations. Do white groups seem to be treated better than black groups, for example, as a frame of analysis? We don't see massive differences in terms of the sort of prevalence rates of those that actually come in to get accepted, that finally get a follow-up outcome. When you put it into a sort of multivariable model, you actually do start to see some discrepancies in various groups. So that's sort of saying is that we're not very good. There is some biases in the way that we're collecting data from the clinical samples, depending on different ethnic status. So what did we do to try and rectify this? Or my worry is it maybe even worsened it. So this is a piece of work that we did, essentially trying to improve the automatic collection of outcome measures. So the system that we built and trialed was we just called it My Healthy, and it took information from the CAMS record. It found the email address, which was almost, there were hardly any email addresses in our electronic healthcare record, and the mobile number, and it spun up a sort of almost like a Survey Monkey type questionnaire. So it would ping a link to a caregiver. They would register on the service, and then they would just simply provide outcome measures. So we're just again looking at the SDQ for the time being. And then they'll get some visualizations, because some of the feedback that we got is that people get a bit fed up about providing lots of information and not getting any feedback. So it really does reduce the kind of likelihood of continued engagement if you don't give something back that they can think about. So we set up this system, but we also knew that you can't just send one-off link. It's got to be repeated, just from our own experience. If you get pinged once, you sort of come to it. And you get pinged twice, that increases your guilt and anxiety. Pinged 5 times, you're probably going to submit. Anyway, so this was what we did. We felt that it was fair to do this because it was fairly low burden. It was a single text that parents got on a weekly basis. First one was to register, and then once they'd registered, if they completed an outcome, they would then, if they didn't complete an outcome, they would be prompted until they completed one outcome. And the idea was, so we had baseline on this group, but then we wanted to see is how many we can actually improve in terms of follow-up. So we randomized groups to this view, sort of monitoring as usual. So this is the paper and pencil type questionnaires that are routinely done in clinical practice. And so 96 families got this monitoring as usual, and 96 were randomized to receive the My Healthy link. And what was interesting is that actually, we ran this over 3 months, and each of these sort of on the Kaplan-Meier curve, each of these upticks is a ping point. So we just every week we just ping them at about just before bath time, just after supper, about sort of 10 to 6. We ping them with reminders, and basically this is looking at the outcome. The central point is the time at which they completed the first SDQ, and everyone, it kept on giving. I expected it to plateau after I thought people will, if you get a couple of reminders, you're in that sort of ignore it camp, and you just sort of don't bother. But it kept on actually giving returns, so less and less increments. We then paused it, so then we wanted to report that as our trial finding. But we then wanted to also enroll the control group as well, because the service were interested about how well the control group covered. By turning on the control group, we also then turned on the experimental group as well. So over time, even after 3 months, people having got a weekly reminder for 3 months was then still sometimes doing it. So they were still sort of, when they activated systems, so this went up to nearly sort of 80% completion rates after a 5-month period, which was just really interesting. Again, we weren't powered to look at this, but I was just generally interested about what it seemed to do in terms of the rates of non-completion, again by ethnic groups, and it really boosted, I think, white groups' completion rates, but it didn't seem to penetrate. We got much greater prevalence, absolute prevalence rates in non-white groups, but it might have actually created some greater separation for those groups compared to white families that seem to be a bit more responsive. But we need to think more about that. So I think basically this is to come round to what else is happening within sort of when you're doing routine outcomes type evaluations, assessments, when you're using mental health data from trusts, just to be wary of. And I think that the ethnic group discrepancy is something to just bear in mind. For example, when we looked at diagnostic adjustments, so when you're treating children, you will tweak over time. You get to know them better, and then you get to sort of refine their diagnoses, often by adding comorbidities, or sometimes actually saying, no, this doesn't feel like ADHD, this is much more anxiety. We'll drop that as a sort of working diagnosis. And what we found is that you get much less diagnostic adjustment according to your ethnic status. You just seem to be less involved or integrated in terms of the way that you provision care, and you tweak and tailor your assessments. And then this is just from an MSc that we supervised last year, is that we also found that DNA rates were much higher in non-white groups. So well, with the exception of Asian groups. So so again, if you're basing your analysis on these types of data where you're reliant on information being provided in the electronic healthcare record to sort of model treatment outcomes or assess disorder rates, etc., you've got to be mindful that there's less information coming in depending on ethnic status. We just don't seem to engage these groups as well. Hence less information. Hence you're going to get less data to analyse. All right, I think I'm rounding up. So another sort of challenge really was, what methodologies can we use from the world of big data or artificial intelligence to improve those things that we know are problematic to do in clinical care? And one of the areas is doing these maternal-infant interaction assessments. Essentially, this is something that really should be done almost part of routinely. This is something that a health visitor might do, or a midwife might do during the early phases of sort of perinatal care. It's just to see how the mum is getting on with their child. Is there anything that worries them, or is there anything problematic? And it is very much a very quick cursory assessment that most with like, does the baby look okay? Are they responsive, or are they not particularly responsive to the mum? That is very to do that systematically and to do that properly is a very involved piece of work, and it's something that Sue Paulby spent a lot of time doing at the Mother and Baby Unit, is trying to apply some of these more objective, kind of highly detailed analyses, sometimes frame by frame video analysis, to look at maternal-infant interaction, and to do things like pick up false smiling, where actually a child is shocked and not particularly engaged with the parent, but they are using some smiling mechanisms or kind of looking excited, where it is related to distress rather than it is actually related to engagement. And therefore you get sort of problems in family court assessments, etc., where unskilled operators do these types of evaluations but don't really interpret the true kind of interaction between the mother and the baby, and therefore make recommendations sometimes incorrectly that the interaction is good, or actually other way, sometimes still the interaction is bad, where actually it's just a normally responsive distressed child and a mother trying to work with them. So what Sue has done is Sue has collected huge archives, of which again, and some of my group, I'm grateful Emily as well, so has done a lot of work about trying to load up these particular videos so they could be so they can go through some machine learning pipelines. And the idea is there is any way that we can actually get good feature mapping on mother's faces and child's faces using Sue's videos to see if we can find some interaction patterns. Very crudely, not particularly refined analysis, but the first question was, can you actually place patch learners from previously developed models to find facial contours, and then actually you can then model changes in these patch learner movements. You can then model these changes and see how well they correspond with a baby's face. Now, that's kind of problematic also, because baby faces are quite chubby. You don't get there isn't the same normal facial architecture. So we were interested to see whether a computer can pick up a baby's face accurately, and can it actually work out where the eyes are, where the nose is. So it was taking the information from Sue's videos and seeing if you impose these machine learning models onto the videos that she had, could it do it accurately? And yes, it can. It can do it quite accurately with a proportion. Where is problematic is if you've got non-white mums and babies. So this was us trying to find. It just couldn't find where it should place the facial analysis profiles on these videos. And interestingly enough, the minute Sue came into the video, it picked up on her face absolutely fine. So it wasn't just the fact this was maybe a grainy video or the angles. It was actually to do with the fact that these are models that have been trained on non-ethnically diverse groups, and if you want to try and apply them into our types of analyses within groups which are representative of multicultural populations, you're going to really struggle. And this is quite well sort of described using the kind of big facial analysis type libraries, where it does very well at identifying age and gender depending on basically the coloration of your skin, where accuracy just gets worse and worse and worse the sort of the darker you are. And in terms of implications for us, it means that we need basically to work on how to get more refined models if we're going to use fair populations to develop these tools on, if we're going to get fair representation of the science that we do. So we sort of, these are questions that I sort of throw everyone around. This is the last time I asked was really about what the Child Psychiatric Research Society wanted to do or wanted to think about in terms of its position statements. But I think it's equally useful for us all to think about is that there is discussion along the lines that is coming down the pipe really about when we're starting to use these types of methodologies, what our ethics panels are going to start to ask about the methodology in which they're applied, how well, if we do, the explainability of the algorithms that we're producing, are they going to be standard supplements that are now really journals are going to, journals are going to take on, editors are going to take on, that we need to provide. What we've got to be really clear on is that if we're borrowing machine learning pipelines from commercial companies, that they can really be clear about the accuracy, because especially if you've got black box work, you're just not going to know. So just to make sure that validation is built into the type of work that you're doing. Now that can be from natural language processing of text all the way through to speech and video data. And then this ability to be able for someone else to come along and actually have a look at your data to make sure that it is doing, your validation studies do seem to be doing what they say they're doing. And I think the whole idea is that you need to do all this to make sure that we're developing technologies that are fair and they are rightly applied, that we are not, again, increasing inequality gaps in treatment and people's capacity to respond to treatment by developing these very nice tools that just work for a subset of the population. And you know, a lot of the natural language processing work that we do at the Maudsley is bouncing around other areas, and the data linkage methodology I described, and the analysis, machine learning of large routinely collected data is not something that's just a niche thing here. It is being pretty much rolled out, not just in mental health, or obviously in physical health too, but local authorities are looking at it in terms of risk of being children being put into care proceedings, for example. So there's quite a lot of hygiene I think we need to do to make sure that we are applying these methods in the right way.
Can I ask a quick question about
Yeah,
that?
sure.
So is that the same algorithm or the same model getting bounced around different trusts, creating sort of a master algorithm, or each trust creating their own model, which would then only be applied in that population or that region?
Yeah, well, let's take the education example that I gave, is that you would probably, in order to set this up, it would be something that could be run centrally across every school, and then you'd get vulnerability profiles per school. So that's one method, which I wouldn't mind, because that's then talking about it in a sort of public health population prevalence sort of way. But similarly, they could be applied. I don't know whether schools school services probably wouldn't be able to put these types of methodologies and devise their own models and then kind of spin it up on a per school basis. They would, because essentially what you're saying is that you can run this over education variables within your population, and it can tell you on an individual basis the probability of them having a problem. Schools wouldn't be able to do that, so commercial companies will come in and do that for you. Okay. And so that my anxiety is the way that if we produce kind of compellingly accurate machine learning tools that are based on education data, they could be misapplied in these examples where they say to a school, look, we can find your vulnerable groups, you give us the groups, we'll run it, we'll find them, we'll accurately identify them, and then we'll treat them. So yes, and I think one of the things we've become aware of is that there's lots and lots of commercial companies probing schools all the time for various educational software tools, for various stratification tools. They're offering quite a lot of assisting education platforms to that group, and because basically the head teachers are the procurement, you have a small group of people you need to convince, if you see what I mean. And DfE aren't providing any real guidelines yet on how to interface with these commercial companies. I think that's it. I think I'm
okay, that's fine. Well, thank you. So we do have questions from St Thomas's, but I'm going to be cheeky and give priority to anybody here if they do, or I can just start with the questions from St Thomas's. Oh yeah.
Thanks, it was really, really interesting. So the ADHD work that you described, have you looked at whether any of those predictors are different by gender? I mean, there's the feeling that maybe like autism, we're not so good at picking up ADHD in girls.
Yes, I think no, I haven't stratified by gender yet, but that's a really good thing to do. And then it's also to think about, if we were to fairly weight, what could we take, what would be the kind of gold standard data set, because we just need some idea about how to reweight based on some gold standard where we felt there's been fair assessment of a population, and then we could pop that in as a sort of part of the weighting algorithm, and just say this is how you, and then hopefully you could produce something that might not just be so distorted by gender, because we just miss a lot. But yeah.
This amazing topic. We appreciate that. When I did my master's, I did some work at the Chris Data Wing Cambridge Institute.
Yeah.
I looked at some of the assessment methods that
Yeah.
use on patient insights.
Yeah.
Using the routine clinical assessments.
Yeah.
Everything is in free text.
Yes.
And what I found was there's less than 10% of all 4,000 records that provide any usable information.
Yes.
So you've identified a very similar question that, like, even for the patient-reported outcomes, the data turnout is really low.
Yeah.
Is there any other ways other than just auditing every year then to really help them improve this?
Well, that was well, certainly that was the hope, that we'd get better data collection So you can't really do anything. If the data's there, I don't think there's any fancy maths that you can do when you've got paltry outcomes, when you've got these sort of, you've only got 10% of your sample. But what I'm also saying is that NHS England, etc., are making decisions, and trusts are making decisions on these very unrepresentative kind of outcome, because that's the only data they've got. So you obviously try and improve the source of the data. What we probably should think about, and I'm wary about the notification work, but a lot of trust systems, a lot of medical systems, Epic is one example, EMIS, it's done in primary care. They have a large number of notifications where you might say, oh, by the way, you haven't asked about this, or could you please ask about this, or this particular individual looks like it might benefit from some further inquiries about this. We don't have that in our current electronic healthcare record system. I don't think there are some mandatory fields when you onboard a patient onto the system, so you should ideally put in gender and things like that. But yeah, improving structured data input, I think, is a dead duck for clinicians if you just produce more forms. That doesn't seem to really improve actually input, they just get ignored. Or if you make them mandatory, you then get quite a lot of pushback about this is improving, this is increasing burnout, etc. So I think what we just have to do is when we put these potentially, we can run algorithms that say that there's empty fields here and you really need to make those fields. It's just to make sure that they're properly road tested before we put them out, and also to have a priority system in the way they do with air traffic with pilots. Is that, you know, when you're dividing something for a pilot, it has to meet a certain severity in order to get a notification threshold, and this is something that's talked quite a lot about. You know, the idea that if you overload clinicians, you get a drop in the quality of data rather than an improvement. So anyway, there's lots of tensions about that.
I'll just ask St Thomas question. So one question is, do you think that in the future large databases such as CRIS will play a bigger role in research and hopefully address issues with small sample sizes? So is the direction of traffic towards more big data? I know this is sort of a buzzword, I guess.
Yeah. Yeah, I think it is. Yeah. I mean, I think HDR UK and all of these big kind of yes, I think they're very much the tanker is turning.
No crystal ball, but
yeah, I mean, I'm also sort of biased because this is this is what I've said I'm going to be doing for the rest of my life. But yes, I think there will be. I still think the hype bubble is not kind of burst a bit on some of the things that we some of the problems that we're going to encounter which relate to data quality and whether we do create algorithms and systems that may be biased, or, no one's quite really fleshing that out. But yes, the whole point is that you can, on really difficult to capture populations like groups with schizophrenia in terms of following up, you can do this using these electronic healthcare records. And the idea, you should be able to build nested trials within these, so you do a little bit of intervention and then you use, for efficient follow-up, these electronic healthcare records, I think is stuff that the MRC and other funders are saying, yes, no, you must do this, and we're not going to fund you to do high quality follow-up and pay you, your RAs to go and visit people's homes. You're going to have to rely on these large-scale electronic healthcare record resources to link to. So that feels like a very much a strategic push that I've come across. I don't know if other groups feel the same.
One final question from St Thomas is, unless there's more, but I think this is, I dovetail it with the question that I had in a way, or just a flag waving, which is, there was a recent paper that was looking at MRI scans and machine learning, whether they could identify patients with depression.
Yeah.
And it was something like 61% accuracy, so it wasn't great. But I think that's just part of the teething process of refining the procedures. But I guess one thing that will help is if our code and everything is sort of made openly available.
Yeah. And
I wondered which standard practice is that, and what kind of barriers do you come up against? Because obviously this is sensitive information, or whether, I mean, I don't know whether yourself, whether you put your code online.
I think you
verify.
You put all the features that you're putting into the models. I think we can't give access to this data because of the governance structures. This is clinical information. No individual level data goes out from it. That's pretty much standard practice by ONS as well. They've got quite really tight statistical disclosure rules. So the actually enabling people to access this data to sort of validate or improve on these machine learning outputs is tricky and problematic. There is an effort to try and create synthetic data based on clinical records, and so it's tricky with natural language processing data because you can't distort. A heart attack is a heart attack. You can't call it like tooth pain. You can't build models on that. But there is increasing push to and efforts to try and create synthesized data based on free text from clinical records, with the idea that you use the same dodgy syntax, that you get the same abbreviations and things like that. So there is a push to do that. But yes.
Any questions on here? Any more
Sort of just linked to that, and sort of was linked to my previous question. There's actually a team or a group at St Thomas, the AI Centre for Value-Based Healthcare, and I went to one of their talks, and they spoke about taking the algorithm to each hospital. So talking about protected data, absolutely essential. I'm not sure how it would link with the age. I'm not early age researcher myself, so would that be something that's applicable to CAMS section? So the researcher with the algorithm or the model goes to each CAMS, and this data stays on site. You train it there, and then you take it.
So to answer your question, yes, I think that is a really important, compelling idea. So you validate based on what trust data. The thing is, you have to get harmonized data. So you have to make sure that trusts are kind of collecting things in a similar-ish way, encoding things and standardization of the types of features that you're putting into these models. But that's the way to go. And then you tweak based on local population differences, where models don't seem to work as well, and say, well, maybe we have to start again. But yes, I think that is the way to go. What's difficult is if you are going into small areas where there isn't adequate resource to run those models and to set them up and do them properly. And a lot of trusts really struggle with that. So you need to have a decent infrastructure that can go around and say, we'll do it for free, we'll support you with the intelligence that you get from it, we'll come back again in a year's time to make sure it's still patent and valid. And I haven't yet seen that nice sort of pipeline being set up yet that looks after trusts or looks after local authorities in terms of their informatics capabilities.
So instead of new hospitals, maybe just upgrading every computer and
it's
digital systems.
No, but it's people actually. The digital systems are sort of not that complicated once you can access a sort of cloud-based resource and you can spin stuff up. It's not massively. It's the people that understand the data then can actually turn it into something that people understand on a kind of policy level or a clinician level, and then we'll come back and do the same thing next year. And when they talk to local authorities about how they use health intelligence and use their various different data sets, etc., they say, that's nice, you can come do something fancy, but we have a PhD student that comes along for 6 months, and then we don't see them for 2 years, and then therefore we never apply what they could do. So it's the
implementation stage.
It's implementation, then also educating everyone so they know what things mean and how to translate them, so they do get into kind of public health reports or joint strategic needs assessments. Because if people don't know what they are, they get frightened of them and they don't want to include that information. So, especially if they're using it to make decisions on. So, I would say the biggest investment we need is just to keep people running, understand these methods, and then actually find a way to sustain them and to support local authorities and various trusts. It's all about people. The tech is all about people.
Any other questions? Comments? No? Okay, well, we'll leave it at that. I've just got a text from St Thomas's. They're sending their virtual applause over.
Oh, great. Thanks, St Thomas.
Trust us. So, yes, thank you. On that time. So, are you okay to pass the slides to me and then I can
Yeah,
circulate? Yeah.
yeah.
So that would be great, and I can pass them on in the mailing list.